We're licensed. What's next?
Everybody has heard licensure is coming, and they've heard the footsteps of the mighty Thor, but we haven't seen anything yet. What is, in your estimations, going to happen next? What's the next step?
Well, first off, everything did take time. The board, it took time for the governor to appoint, and then it took time for the board to finally have its first meeting. The whole process of licensing takes time. Typically, getting the rules and regulations for licensure approved is often an 18-month process. It has to go through the legislature and through all the different governmental offices. We're trying to get this done in half the time, in 9 months. So we are just finished with the public comment, and it's the website is open for additional comment on the initial rules and regulations. The anticipation is we should be fully through the process by end of December with the first licenses going out first of the year. Now understand that things might come up that could set that time frame way back or delay it slightly, but it looks at this point January sometime we'll be sending out the first licenses. And you'll have 1 full year to apply for your license and receive your license. And during that first year, the only thing you'll need to prove is that you are at least a certified respiratory therapist. After that year, a year from January, then you'll need to have not only a CRT, but also graduate from a respiratory program and have an associate's degree.
Well, I have heard people express concern that now that we're licensed, that it's going to hamper the way that they practice, or that they won't be able to do things the way that they did before. And I don't see why that should change in any big way. If I've heard people say, oh, we were more creative before, we can do what we want and not worry that it's going to catch up with us. Well, to be honest, we probably shouldn't have been so cavalier in the past. So I think if we go through the proper channels, we're still going to be allowed to be as creative and as resourceful, and still be able to investigate the way that we should. I don't see license, now that we're licensed, that should restrict us in any way.
I've always been a sort of an advocate for the idea of licensure for our profession. I think licensure is that certificate of adulthood. It means you are someone who can stand on your own, no longer the child of physicians or of nursing. You're an independent professional practitioner, and it's really analogous to that as a child grows up. You know, the child always seeks to become their own person, and I think licensure gives us that kind of recognition in the society, within the healthcare arena. We are our own profession now. Along with that comes some responsibilities. We're going to have to live up to those standards and be independently responsible for being good at what we do and for the decisions that we make. But we're also recognized as being a professional now because of that licensure.
Having reviewed several legal cases, I can tell you that we've always been held to a standard of care. It's just you didn't realize it until you were called on the carpet for it. So I don't see that, again, that changing, but we'll be more aware of what the standards of care are because there's more interest in it. But I don't think it's changed that now we're held to a different standard of care than we were earlier.
Well, the nice part about the license is it doesn't limit what respiratory therapists can do. We all know, going from hospital to hospital, that some places do intubation, some do blood gases, others do different procedures. The bill does not limit our job. In fact, it also opens the door up for us to do other procedures, other things, as long as it is allowed in our institution and that we've been trained and competently assessed to do this work well. That's where you have to have individuals, when you're looking at the ICUs, that are competent, that have the training, the advanced practitioner training to your degree or longer, and the RRT credential, I think, is essential in assessing that competency.
Going on the flip side, for skilling of therapy, we're looking at typically patient assessment, development of a respiratory care plan, implementation of the respiratory care plan, any level of ventilator care, life support, and those high-level functions that require the specific skills and training of a skilled respiratory therapist. Now, we will be debating over the next year or so what procedures constitute skilled versus non-skilled. Now, when you go to another group of individuals, the unlicensed assistive personnel, they will, aides, assistants, techs, general helpers, etc., they are prohibited and not permitted to perform any procedure, a respiratory care procedure, that is deemed skilled at all, period, end of discussion. And that is by statute. They can perform non-skilled respiratory care procedures only after documentation of competency-based training conducted by a licensed respiratory therapist, and only under the supervision of a licensed respiratory therapist.
Well, I think over the last 30 years, those of us who have started early in this field, we have worked as a respiratory therapist underneath the physician's license. We've taken that for granted. Now, with our own license, we have the shoe put on the other foot. We are now responsible to observe and supervise unlicensed individuals in our field. Those individuals will be new graduates that have not passed the credential test and students who are working in the area, and it becomes important that we know their limitations. Each hospital needs to establish policies and procedures that they can do, assess those procedures that the individual is competent in, and then make sure that the supervising RTs know that this is what these people can do and that they cannot go beyond that, and that they're assessed as competent.
I would refer you all to a document, which is a matrix on guidelines for supervision in the practice of respiratory care, which has been approved by the Michigan Society for Respiratory Care and has been published on our licensure webpage. In a nutshell, licensed respiratory therapists will be able to perform without supervision any procedure that is in our scope of practice, which is skilled or non-skilled. Other licensed health professionals, such as RNs, PTs, RPH, MD-DOs, etc., who are operating within their scope of practice, may perform overlapped elements of the respiratory care scope of practice, skilled procedures, provided that those procedures are also in the other licensed health professional scope of practice, with their supervision being their supervising health professional. And they should be able to also perform non-skilled procedures, provided that they are in also their scope of practice.
We've tried to put together a proposal to the governor's office and then ultimately to the Board of Respiratory Care, which are appointed officials from throughout the state. And they have the final say, and they'll have to approve whatever gets put into the rules. But the committee I've been working with has drafted a proposal. The idea is trying to take us a step beyond just simple continuing education units. A lot of research has illustrated that continuing ed units alone are not sufficient to assure competency of the individual practitioners. We've come up with a program that emphasizes professional development credits, and individual therapists can earn these credits, must earn these credits in order to maintain their renewal of licensure on a semi-annual basis.
I think one of the new things that we're going to be seeing is as the licensure process evolves and a continuing education program gets integrated into the process, the process that we're recommending that the state use is actually a fairly, not necessarily revolutionary, because it's a model that we have discovered that's being used in Canada, is being used in Europe, is being used in New Zealand, in Australia, and is being used in the United States here at a national level for several different professions. But it's a process that's we think is at the cutting edge for healthcare professionals. And the whole focus isn't to guarantee that someone is competent. It's a process that will make lifelong learning an integral part of our practice.
Well, I think one of the things that we have not done yet as a board is identify the CEUs, or competency testing, part of continuing education. That is going to require more and more out of individuals, that we stay current, we stay competent. So yeah, I think in the hospitals there will be more things happening educationally just to maintain our licenses. The state wants us to really design a whole new system and not use CEUs, but use something other than CEUs to measure our competencies, and that's going to reflect back on the individual hospitals.
Its focus is on continuous professional development. It's a focus on trying to figure out the elements that you're strong in, the elements that you're weak in, putting together a development plan, going out and obtaining those educational credits focused on your weaknesses. Part of the process is learning in the environment that you work. We're calling it event-based learning. But when something occurs on the job and there's a teachable moment, we want to come up with a process that you can document that moment, and that you take it several steps further than what you traditionally would, that you actually do some formal learning about that particular incident to increase your professional practice for the future.
Having a licensure bill means that respiratory therapist individuals are going to have to maintain continuing education and competency development in order to maintain that license, and that ultimately translates right back to the bedside. When that event occurs, that individual therapist is going to be better prepared to make the right decision, do the right thing for that patient.
What do you consider skilled therapies? It's not everything. The days are long gone in which respiratory care departments have to validate and justify their existence by grabbing every single procedure that they can within their healthcare facility. Those days are long gone. Are we going to throw a registered respiratory therapist, a licensed critical occupation health professional, at every single low-level, technical level task? My answer is no. Do we need a registered respiratory therapist or a licensed respiratory therapist to check the position of a float in a Thorpe tube on Q-shift O2 rounds. No. Those are non-skilled procedures. So the days of grabbing every single procedure to validate our existence, those days are long gone.
However, often you hear people say, well, because we have licensure, does that guarantee that people aren't going to get hurt, or that it's a guarantee that that licensee is safe? And my comeback is that it's similar to a driver's license. Because someone has a driver's license doesn't mean that they won't drink and drive or that they won't get into an accident. But what it does guarantee or suggest is that in order to get the initial license, they had to do something. They had to take a test. They had to practice or demonstrate competency in a certain level in order to get the license. And then if they cause harm in the future, we have some recourse to hold them accountable. And I think that that's similar with being licensed in a healthcare profession. To get the license, we have to demonstrate a minimum level of education and competency, and then we have to do things in order to show that we continue to be competent. But it doesn't mean that we're never going to cause patient harm, make a mistake. But if it's a grievous enough incident against a patient, we can be held accountable and lose our license, which
Hi, my name is Al Moss. I'm the Program Director for Respiratory Care at Kalamazoo Valley Community College. I'm the co-chair for the Legislative Committee of the Michigan Society for Respiratory Care. John Darren and I were co-chairs of the Legislative Committee when the Michigan licensure bill was passed for respiratory care. Once the deadline for obtaining a license occurs, practicing respiratory therapy without a license in Michigan will be considered a felony. The real question is, does all respiratory therapy need to be practiced by a respiratory therapist? My bias is that respiratory therapists can delegate unskilled procedures to unlicensed assistive personnel. Guidelines for skilled therapy have been developed by the Center for Medicare Services. These guidelines use two criteria for defining therapy as skilled. The first is the complexity of the therapy. Most would agree that managing life support systems is very complex therapy and should be performed by licensed respiratory therapists. Therapies such as uncomplicated medication nebulizer may not necessarily require the skills of a respiratory therapist. However, we now need to consider a second aspect of the definition. The second aspect of the definition is the complexity of the patient. Most of us would agree that providing medication nebulizer therapy treatments to a patient that is in status asthmaticus would require the services of a licensed respiratory therapist. So even the most basic respiratory care procedures should be provided by a licensed respiratory therapist if that patient is complex. If unskilled therapy is being performed by unlicensed assisted personnel, supervision by a licensed respiratory therapy would be required. There are 3 levels of supervision. The first level is personal supervision. This means that the licensed respiratory therapist is in the same room as the person giving the therapy, while the unlicensed person is giving the therapy. The second level is direct supervision. This requires the supervising licensed therapist to be in the general area of the unlicensed therapist. Most of us define this as being in the same building. The third level of supervision is general supervision. This level of supervision requires that the licensed therapist be available by telecommunication. The level of supervision required depends on the competency of the respiratory care provider. Licensed respiratory therapists are considered competent because of attaining their credential. The only supervision that may be required for licensed therapists is general or maybe direct supervision. Now, what about the unlicensed person? The competency for that unlicensed person is the responsibility of the employer. The employer should maintain clear and very specific documentation of how they assured that this unlicensed provider was competent. Personal in-room supervision would be required while the unlicensed assisted personnel, this unlicensed therapist, was learning how to perform care and has not yet demonstrated competency. Direct supervision would be required of the unlicensed person who has demonstrated competency in performing unskilled therapy. My bias is that general supervision would not be an appropriate level of supervision for unlicensed assisted personnel. You would not even have somebody in the same building with this unlicensed person. It would not generally be considered appropriate to delegate complex therapy or complex patients to unlicensed assisted personnel. Providing complex respiratory therapy or providing respiratory therapy to complex patients could be considered practicing respiratory therapy without a license and could be a felony. It is clear that the person who meets criteria for a license or attains a temporary license will not be practicing respiratory care without a license. The purpose of the licensure law is to protect the citizens of Michigan. The profession should assure that complex therapy and complex patients are only cared for by a licensed respiratory therapist. I would encourage therapists to check the MSRC webpage for the MSRC's published statements on skilled respiratory care and the statements on supervisory requirements.